Welcome back, Health Impact audience. You guys got a really good taste about cybersecurity and other issues associated with all the technology that we've been deploying. But you know, one of the biggest problems that we don't always talk about a lot because it seems like it's, one of those solved problems about how you do claims management and how do you do billing and those kind of areas. And it really turns out that those are not unsolved problems, that in fact, it makes up significant percentages of the cost of healthcare institutions that they have to take care of bills and invoicing and getting patients who are late in paying to pay, and then getting payments from insurers, et cetera. And that's why I'm really excited to have this conversation with Automation Anywhere, who's been really focused on these things from both from a machine learning as well as robotic process automation. But more than that, just thinking about what are the fundamental problems of the complexity in getting paid for the work that healthcare providers do. And if you look at that and just say, look, with all the technology we're putting in, how the heck do you still get paid for the work that you are doing? It's a real problem. And if you tack on the new law, the No Surprises Act, or the NSA as it is referred to by those working it, now you have this entire other problem where in the old days you could say, all right, we missed a bill here, somebody forgot to record something over there, and so I can just bill the patient for it. Well, now that's going to be called a surprise, and somehow you're going to be held to task for doing something nefarious, like surprising the patient with a bill that you didn't know you were going to accrue before you did the presentation, before you did the service. So when you look at this complexity, you're like, man, there's got to be something out there that we can do to help reduce the administrative costs, get paid at or above what we want to, without breaking both ethical as well as actual laws around this surprise billing. So that's why I'm really excited to have Tyler and Yan from Automation Anywhere to just break this down into layman's terms about what is going on and what do we need to do. So with that, Yan, please introduce yourself, and then I'll have Tyler do the same, and then I'll ask you the first question.
Thank you, Shahid. My name is Yan Chow. I'm a physician, pediatrician by training. I spent 32 years at Kaiser Permanente, the last 8 years as the Chief Innovation Officer for the nation. Also spent a lot of time in biotech with Amgen, working on digital medicine, as well as in Washington, working with the VA and DoD on startup technologies. So I've been with Automation Anywhere for about 2.5 years, helping to launch the healthcare vertical. So I'm glad to be here and glad to meet everybody.
Fantastic. Tyler, tell us a little bit about yourself and just describe what is Automation Anywhere and what do you guys do?
Sure. My name is Tyler Stoll. I've been here at Automation Anywhere for about 3 years. I run the revenue cycle management practice. I've been in healthcare for about 20 years, doing various platform deployments and consulting, bringing efficiencies and automation through business process management, automated workflow, as well as RPA. So what do? We drive net efficiencies around cash management, revenue cycle recovery, and management. So the team looks at the various providers that are out there, and we see what we can bring in terms of value to shorten the time to cash, as well as compressing their denials volume to reduce the amount of write-offs that the CFO has to make month to month.
Yeah, and one thing that I love about what Automation Anywhere does is that it gives us the ability to go pay for all the other stuff that you want to do. Like, if you can actually do this right, you actually get paid for the work that you do, you will have then some money left over to do all the other cool technology stuff that you want to do and all the other go to Mars programs that we all really want to work on. So it's one of those things where if you don't handle the payment side of things and you don't handle the money, the cash flow side of your business, you can't actually do anything else, right? So you can't hire people, you can't do any more technology stuff. So that's why it's really, really important. So before we jump into the detail, yeah, and just tell what the heck is this No Surprises Act, and how are we supposed to know what is a surprise or what is not a surprise when it comes to billing? Just tell us what's going on here.
Well, there's a lot of surprises to go around in healthcare, of course, but the No Surprises Act, which was passed by Congress late 2020, went into effect just a couple of days ago on January 1st really takes aim at the unanticipated or surprise medical bills that come to normal health concerns. It turns out to about switch be generator. Well, surprise medical bills happen when insured patients receive care from hospitals, physicians, or other providers who do not belong to that patient's insurance company's network. Patients are often unaware, actually, this is happening. And I'd like to share a slide that takes a look at the high-level process. So
Oh yeah,
let me
that'd be
go ahead and
perfect. Go
share
ahead.
the screen. This is the traditional process, and I'll walk through it a little bit. I think it may help to have our audience understand it. So normally in healthcare, a patient gets sick. They receive medical services, number one, when they go into a hospital, and the hospital utilizes both providers that are in the network of the insurance payer that the patient is enrolled in, as well as out-of-network providers. Later on, when the care is done and the patient is discharged, the hospital submits a consolidated claim to the insurer. And of course, the insurer will, in response, pay the coverage amount, the amount that they are contracted to pay. And then what happens is, of course, the hospital balance bills the patient, and that's the surprise, the very unpleasant surprise that happens. So with the No Surprises Act in 2022, this is going to be what happens. The patient first must receive a good faith estimate if they're uninsured or they're self-pay. And this is really important. This GFE, we call it, before they agree to medical services. And if the ultimate cost is over $400 over this estimate, then they can arbitrate for a nominal amount. And this is really important. So now the uninsured patient is at much less risk of getting a surprise bill. Second thing is, of course, they go into the hospital, get the care from both in and out network providers. But now, instead of balanced billing, the hospital and the insurer must engage in an independent arbitration process to negotiate the payment of the costs exceeding coverage. And I think this is really interesting because it does protect some population of patients. Now, does this apply to patients on Medicare, Medicaid, Indian Health Service? It doesn't, because those programs have their own protections. So this is the actual process of the negotiation between the provider and the payer. It's a 3 to 4 month process. And I've outlined some of the steps that could be automatable, actually, because this process is going to require a lot of resources, a lot of time, investment on both the payers and providers side. And so this is really interesting because it's very early. It's early in the days of this act. But as people start to think about what it takes to do this for quite a few patients potentially, is going to have a huge impact. So I think it's a very interesting act because it's very focused on the patient, but it's going to affect, as you said, the revenue collection piece of the puzzle quite a bit. Yeah.
Yeah, perfect. No, that was great. So tell us a little bit about it. And Tyler, you're welcome to jump into here. Is what is the reality of the impacts if you do nothing? Let's just you say, hey, I don't even care about this no surprises thing. It's not going to mean anything to me in my daily work, et cetera. What is the risk to health systems by kind of ignoring what the No Surprises Act is doing? And Yan, you can start, and then Tyler, you can jump in.
Yeah, I think obviously the impact of the act is potentially huge. It changes the revenue cycle, which is the major piece of the puzzle, the major part of the operations that is so important to healthcare. Patients, of course, will benefit in not having to worry, about these unanticipated charges. And actually, analysts have looked at the NSA and estimate it'll make less than 1% difference to insurance premiums. So that's really good. The insurers themselves will probably experience significant impact from the resources required to engage in this process. And I think that's something that they're starting to find out, they're starting to work out. And this is a great opportunity for automation, of course, because the goal of automation is to make a lot of the repetitive manual processes work much better. I think the most important impact will be for providers like hospitals, specialists, especially in the emergency room, anesthesiology, radiology, and strangely enough, air ambulances. that are going to be affected, because they have traditionally stayed out of provider networks so they can charge more. And it's in some cases it makes economic sense because they may be the only provider in a small town or whatever, so they will stay out of the network. But of course, with the NSA, many provider organizations are now concerned that the NSA states that during arbitration, the starting benchmark for an acceptable reimbursement is the in-network rate. So of course, the payer has huge power because all they need to do is set a very low rate. And that's where the arbitrator is supposed to start, which is of course going to engender a lot of pushback from the providers. So the other thing is from a perspective of the financial perspective, a doctor, whether they're in a network or not, is now for all intents and purposes in the network. And so I can anticipate that there'll be a huge influx, or maybe a huge influx of new physicians into networks, which will put demand on credentialing. It'll put demand on resources of the hospital and so on and so forth. The other interesting impact is that if there's less cost difference among specialists, there'll be increased demand for premium specialists, people who work at Harvard, Stanford, and so on and so forth. So for the non-premium specialists, how do you compete? There'll be more incentive to do unique differentiated capabilities, out-of-pocket payments, specialty niches, training in certain advanced techniques, and so on and so forth. And for the premium specialists, there'll be more incentive to prioritize high profit services that are covered. And I think that's going to be very interesting to see. But I think ultimately only time will tell how the balance of power will shift between providers and payers.
Yeah, makes sense. So I mean, you did some beautiful explanations there. So cut back months of reading in the nice digestible few minutes here. Tyler, extend on that and say also if you want to expand on how real this is and what it will mean day to day. But it seems to me the first and biggest risk area is in coming up with that GFE. If you don't get that GFE right, it seems like all the other problems are going to just be downstream. So expand on what Yan was mentioning and how real this is and what it matters. And then say, well, how the heck do you handle this GFE using your current business processes if you can?
Yeah, I think I'll first look at it from the provider billing perspective, right? The CFO each month has to write off a certain percentage based on a various number of factors. We know that in the market today, there's a huge labor shortage in the medical billing space, in the provider space itself. So there's ever exceeding backlogs. And so those thresholds, those write-off thresholds continue to increase. So there's lost revenue. So what this opportunity provides is to the market is an opportunity to recover some of that lost revenue. What we've seen in Texas, and Texas was one of the first states, the Department of Insurance, as we began to look at the use case, the ruling, there were certain parameters there that, the set a threshold of say $5,000. You could bundle a number of previously denied claims, but it cannot exceed the $5,000 mark. And there's case assembly. So with those denials, you have to assemble a large packet of information that has to provide all the necessary information to adjudicate the case. There's a legal review. So we're seeing there's a lot of labor required to comply with this law. So you think in terms of the backlog of cases that could be created by trying to comply. If you're unsuccessful in the arbitration case, you could lose that, which is further losses. If you're successful, but let's say that the case cost you $1,000 to assemble, your maximum recovery would be $4,000 if the threshold were 5. So it brings up a very interesting mathematical problem. Even though the rev cycle teams and the CFOs would very much want to recover that lost revenue, the way and manner in which you have to expend labor to get to that filing, plus the percentage of wins versus losses, make it a very labor-intensive effort. We do have customers that have been looking at it. There are other states that are going to be coming online. Each state Department of Insurance may have its own, package thresholds and things like that. That's to be determined. So there are some unknowns, but it seems to be, at least on the face, that there's going to be a lot of effort, human effort, 5 hours, 8 hours per case in order to get the package out the door.
Yeah, and so Tyler, what you're saying is, one, you can't ignore it. Two, the benefit, if you do ignore it, will accrue basically to the patient because they don't have to pay it, or they can somehow fight for it now differently than they were before. But what you're saying most importantly is that it is an automatable problem, right? This is not like one of those things where you say that, oh, we're not quite sure how we would automate it, or we have to do years of discovery to figure out how do we, no, this is it's a law problem and it's a finance problem, both of which have the ability to be automated. So just provide some color commentary on how automatable is this? Is it a buy it, set it, and forget it? Or is it a buy it, let Automation Anywhere train personnel and then continue to operate in partnership? How does that work?
Well, I think the rev cycle function would require allocated team to have bot-assisted case assembly, to understand the submission policies and rules set forth for each arbitration case, and then to create the necessary form letters, if you will, that capture all of the fields and all of the medical record components. Now, you can't release the medical record, but you have to make reference to it. So all of the necessary elements in form letter complying with the state filing requirements that would allow an arbitration team to review the case and reach out to begin case review. I would say that is probably 90% automatable. The human effort would have to be to review a legal attestation to make sure that everything is accurate prior to submission. So if you're looking at, say, a 5-hour effort and fully manual, you're less than an hour to do so with bot-assisted support for that case filing.
Yeah, and I think there's different parts of the process. That's really good, Tyler. I think there's a federal and a state aspect to this, and every state, of course, is different. But just as an example, Shahid, you mentioned the good faith estimate, GFE. And I think that there are different kinds of patients. The first patient is the uninsured, the self-insured, uninsured. That's where the GFE is required. What does that require? It means that you have to have instant or near instant access to all the factors that go into that estimate. And that's a process of data gathering that's very tedious and sometimes subject to human error. And so if you give the wrong estimate, you're going to be in huge trouble. The other kind of patient is the insured patient. And for that patient, you need to understand their coverage. And this is becoming a very important point. If you don't know the coverage and what it covers, what it doesn't cover, then you're going to start, as a hospital administrator, you start allowing the doctors to start ordering specialists to come in, and who is not in the network, who may be in a network. All these kind of things may or may not be covered. If you don't understand how the patient's coverage is, how wide it is, how broad, how deep, you're on the hook. You will have to go and argue with the payer later. And I think that's causing a lot of worry, among providers.
Yeah, and did I hear you correctly that the GFE is only required for uninsured?
Uninsured,
you meant
right.
Both, right?
Right, uninsured, and no, it's not required for the insured, but for the insured, the onus is on the provider to actually understand the coverage.
Coverage, right. And then so for the uninsured, you have to do the GFE, and for the insured, the thing that should scare everybody is that if you do something in which you then have to fight with a payer afterward, that's a lose-lose proposition. Right?
Exactly.
So that is something you want to absolutely avoid.
Right.
And that's really where, so Dr. Chow, talked a little bit about what could the healthcare systems be doing today to better prepare for this? So even before you bring in, say, an automation solution like Automation Anywhere and bring in personnel and services to help there, how do you get your own house in order so that you're ready for the Automation Anywhere to come in and help?
So I think at the point that a patient comes in to need services, you have to have a mechanism, and it's usually going to be automated or will have to be automated, to understand where each physician that you contract with is in terms of the network that that patient belongs to, and what services are covered under that arrangement, as well as the qualifications of that physician. So all that stuff is not just to help you understand your risk, but also to negotiate with a payer. So for instance, if you understand, like I mentioned before, that you have to use a neurosurgeon and they're the only guy, or he or she is the only guy within 10 miles and there's an emergency, you have a good basis for claiming that you had no choice and the payer would have to pay that. So, but you have to know that. You have to understand the risk factors. I think that's the piece that's missing when you in healthcare, because of all the silos, we often don't have a holistic picture. we can't make a cogent argument. You know?
Yeah, that's exactly right. So as you start to think about this and say, all right, surprise billing is here. It's the law. If you don't handle it, you could potentially be losing hundreds of thousands, potentially millions of dollars, depending on how big your organization is. You have to do a little bit of preparation work, and then you can bring in the automation anywhere type of solution. What does that look like as far as bringing you guys in? What do you do actually for that? Is it pure technology mostly, or technology plus services? And Tyler, if you want to talk a little about the execution side, and then Dr. Chow, you can talk a little bit about what parts of the care process, if anything, need to change in order to properly handle the surprise billing. So Tyler, we'll let you go first about what does it mean on the ground when you guys come in?
Sure. So we have a dedicated healthcare practice led by Dr. Chows, and we have a number of professionals that support the team. We tend to like to understand, the underlying data. What's the denial volumes look like? How's the data stored, so that we can think through how to assemble the packaging. We tend to issue a certain amount of licenses necessary to support and facilitate that use case. These designs, if you begin in, say, March, we can have a production run up and running in about 2 to 3 months for that particular use case, depending on the complexity. So having access to the necessary data, that's important. Most teams have that. The form letters, right? And it's just then piecing it together based on the specific state, the rules, the filing guidelines. So you can kind of go through a checklist. The bots will execute that checklist very quickly. So before you submit it, the worker will look, is everything in order, hit the submit button, or then manually submit it, and you're off and on your way. Dr. Chow, how would you subscribe?
Yeah, I think that there is a process that seems to work well. It includes understanding for the customer to understand us, and for us to understand the customer. But it's interesting because I think this NSA event is going to really change the way we look at transparency for patients. You've talked about what differences it make to a patient. When you go into a restaurant these days, it's very interesting. You see the calorie count for every item. So when you pick from a menu, like you would in a hospital, if you can understand the cost and the qualification of the surgeon, if you were, your cognitive ability were good enough to understand, that you can make a judgment. I can see the day coming when transparency of that degree will be required, and therefore it'll perhaps do away with a lot of proprietary agreements and things that are under the table, including payer side. So I think it's going to affect the patient from a visibility point of view, and I think that will probably help them be more comfortable with the decisions that are made, because they may have a better say in saying, I'd rather choose this, or I'd rather pay for that surgeon, even though it's more, that kind of thing. But I think for the patient, hopefully, the advent of value-based payment will keep the quality high, because you can imagine that one criticism is the payers will go to the lowest price, all the time. So
yeah. So Dr. Chow, talk about this problem where this is a brand new law. Not everybody understands it. You guys have a much better idea about it than most other people. But who have you worked with? You don't have to mention actual customer names, but give us maybe a large health system with N number of beds worked with us on ABC. What I'd love to hear is, what are some of these originators of this project now? I mean, the rule has just gone into effect. What are they doing? Where are they getting stuck? And how are you helping them with new revenue capture, or revenue capture that they did not know would be possible?
I think it depends on the mix of patients that a hospital has. As I mentioned, Medicare, Medicaid, VA, all that they have their own protections against surprise billing. And so if the hospital mostly deals with those patients, they should see fairly minimal impact. But as we know in healthcare, a lot of hospitals have legacy systems that don't work so good. And so they often will have trouble responding to new laws that require new data reporting, new monitoring requirements. And so I think a lot of hospitals are in the evaluation mode, because the law really kicked in January 1st. So we're right at the beginning, and they're trying to figure out what it would take human or bot wise, to take care of this. And I know Tyler's been working with some organizations, and maybe Tyler, you can speak to that a little bit about the issues and some of the insights that you've gotten? Yeah.
Yeah, so again, we work with primarily rev cycle teams. They have a lot of infrastructure and data at their fingertips. So it's really understanding the denial trends, which of the denied cases are arbitratable. Do they fit the state filing rule? Each state, because we're not completely sure, will have a different set of filing requirements. In Texas, for example, it was a $5,000 threshold. So you can bundle a number of claims not to exceed 5,000. So you look at the total denial volume and you go through an exercise to say, okay, first of all, are all of these arbitratable? Do they meet the conditions? If yes, then how do we bundle them? And then on a payer basis, collecting all of the data in form letter format so that the case can be compiled to meet the threshold, reviewed, an attestation made, and then a submission made. And then just keeping an eye on the labor, because it's going to require a number of people in a department to sort of dedicate their time. So if you're going after 1,000 cases a year, what does that look like in terms of effort, and is it worth it? If you're going after 10,000, 20,000, 30,000 cases, depending on your size as an organization. So it's really basic mathematics. And I think that's where a combination of, a healthcare team that understands the reg, that can help interpret, that can help work with you on the state filing requirements, and then inform the rev cycle team how to do it, right? How to assemble these cases, leveraging automation technology to compress the labor required to get those cases out the door and win.
Yeah, yeah. And so, Tyler, as you think about the objective of automation and any intelligent automation that you would work on, it seems like you want to focus on two subject areas. One is maybe the GFE, making sure that's correct on all the other risk areas that Dr. Chow talked about. But it seems like the dispute resolution process is where everything might get stuck. So what have you guys learned so far? It's early days, but what are you learning about what is the difficulty of dispute resolution based on lack of information? Any color commentary on the dispute resolution process itself?
Let me just throw up the slide again.
Yeah.
If you don't mind. And
sure, go for
if you
it.
look at this process, it's quite a lengthy process. And what the law says is that they're giving essentially 2 months for the hospital and the payer to settle. And if they can't do it, then they go into the IDR process, the independent dispute resolution process. So there's a lot of chance that the hospital with some experience can look at this process and go, okay, it's going to cost us X amount of dollars to go beyond the settlement piece. And so they have an incentive to settle, right? But let's say a significant number of patients go through and they cannot agree, payer and provider. And so they go into this process, which is in the right upper corner here. Then they notify HHS and they want to initiate this. And then pretty soon after that, they have to start to choose an arbitrator. And of course, at any of these steps, there could be a glitch. They may not agree to arbitrator. And right now, I think there's only a few arbitrators approved by HHS. So it's a neutral party. They identify the entity, and then they have to prepare the case for each side. And that's, like Tyler is saying, on the state level, that's a lot of information you have to gather. Medical information, justification, the providers available, who's qualified to do the case. All these kinds of things have to be factored in, built into the case. And then with this NSA process, you submit the information, your best case. And then within 30 days, the arbitrator makes a decision. And it's interesting. It's called baseball style rules. That is, they pick one or the other. There's no compromise. So you have to make the best case you can. And then the other party, the losing party, will pay for the cost of this whole process, which is set at $200 to $500 per determination. But you can imagine if there's 10 patients, that's $5,000. If there's 100 patients, it's 50. So it can go up pretty fast. And so the cost of the process and the time and the people it takes, what automation can do is make this much less costly, much faster. And so it gives you an alternative essentially to settling for something that you really don't want to do. And I think that's the hidden message. It's still, like I said, Shahid, is very early. Nobody knows the level of risk because there's not enough experience to understand how to make that judgment, how to go forward or really try to settle. And I think for the patient, the great thing is that they don't have to think about this. They kind of let their insurer. Of course, if they cost too much money, the payer may send them on to another payer. But that's down the line.
And I think that was the most important part of this discussion, is that what is flipping between the before the act and after the act is that hospitals could have just said they're going to fight with Shahid directly. Now Shahid's like, hey, dude, this is not my problem. You have to go fight with the payers directly.
That's right.
And that's a big shift. That's not a small thing that changed on the side. It's a massive shift. And now we have to think about it in two ways. Do we kind of like let it go and see what happens, or think about it in a more disciplined manner? And I would recommend this maybe in the last couple of minutes that we have left in our talk here is, if you did this properly for the Surprise Billing Act, you're going to put in intelligent automation. You've got the capabilities to do all the packaging and everything. What side benefits would you get? And either Dr. Chow or Tyler, either one of you could say, look, if you just did this anyway, unrelated to surprise billing, here are the 3 or 4 other things you would benefit out of just doing this work anyway.
So I could take a first stab. When we work with our rev cycle customers and we analyze their business and their KPIs, we spot, the reasons for denials, the spikes, and we go after those high volume denials and address those first. Once you're operating with a customer for 6 or 8 or 10 months, you start to see downward trend. You start to see faster cash recovery. You start to see a smaller backlog, which is very, very good.
But so hang on, what you're saying is just by the act of you guys helping to look and analyze, you're making improvements anyway. Is that what you're saying, Tyler?
Actually, when we're in production. So if we're in production with a number of, status acquisitions, fully automatable, denials, about 37% straight through processing on average for a large provider system, the CFO starts to take notice because now his write-off thresholds can start to reduce. And that's very positive for cash flow and the balance sheet. During COVID, we've seen access to healthcare decline precipitously and denials spike, which is the perfect storm for trouble for cash. And with reduced labor, that's now an added pressure. So automation creates a resilience buffer that gives the CFO additional tools to go down the stack. So maybe he writes off everything below $250. Now he can go down and pursue everything to $50 because the bots will go through and many of the claims are just, a single appeals package and they straight through process. So they can recover more revenue with less labor, less effort, less cost.
Great. And Dr. Chow, this is the last minute that we have. Anything you would add to that? What benefits do you get accrued otherwise?
Yeah, I think one of the things that really struck me about this kind of technology is the size of the benefit. And it's almost unbelievable, but we've seen, repeatedly in the industry that you can now you can automate millions of transactions. You can get over hundreds and maybe even millions of hours saved, which is huge in healthcare because we're so short of people. Accuracy to 100%, which is always nice. The human error rate is about 5 to 10%. That's rework and expensive rework. So we can cut that out. Productivity usually goes up by about 30, 40% for the folks that are working with these digital assistants. And the cost savings for the CFO, 30 to 40%, mostly in the form of FTE cost savings. And most organizations do not lay off people because they're so short. And so they repurpose the people, they become much more productive and, raise all kinds of other metrics. But I think this is one really good approach to this new kind of regulation, this really big change in revenue cycle. And I'm very hopeful that it'll sort of start us on the road to redesigning medicine.
Yeah, and I love the way that Tyler said it earlier as well. And I think you just doubled down on that, is that don't treat this law as something being done to you, but as an opportunity to say, look, we needed to do all this stuff anyway. Let's just take this opportunity, get the automation going, and 80% of it might help for other things. In addition to 20% specifically for just the No Surprises Act. So that's how I think the most innovative health systems look at these kind of problems when a new law comes out, is don't think something is being done to you. Your patients are actually going to be happier, right? Because they're seeing that they're coming to an organization that's going to help them make sure that they don't get surprised. So take that as an action and then use what is required on you anyway to
Right.
get an enormous amount of other benefits that you guys have
Right.
already stipulated a number of times. So that's fantastic. I mean, I can see no reason why you wouldn't just want to start to do this intelligent automation anyway. So any last minute words that you want to add, Yan or Tyler?
No, thank you for having us on. I think it was a good opportunity to start looking at what I'm sure will be first in a number of different kinds of laws coming out to increase visibility, transparency, sort of equalize the playing field in a sense. And so I think medicine is taking some of the necessary steps, maybe being pushed by regulation, but taking some of the necessary steps to really become sustainable in the 21st century. Right now, it's not sustainable.
That's fantastic.
Yeah.
All right, great. And we've got
Yeah.
another power panel right after this, talking about how you can do good patient engagement and then tie that into proper patient satisfaction. So this is perfect about costs and charges rolling right into some really good patient engagement from the Emmy team. So thank you so much, Tyler and Yan, for this explanation. Helps us all understand what all this is about. And for the Health Impact audience, please join us in our next session.
Great.
Thank you, Shahid.
Thank you,
Bye
Shahid.
now.